over to you, Ajit.
Thank you so much, Nazar. Just a couple of more things which I found very helpful when I was doing interview. Please make sure that you are wearing decent clothes. Okay, I wore a coat like a smart coat and a tie like how Nazar is doing, with probably slippers on. Okay, it doesn't matter what you are wearing in your foot, but obviously the top should be decent. You can keep a glass of water on your table because you might get thirsty during the interview. If you need to take few some medicines which you usually take in the morning, please do take them, okay, because you won't be able to leave the interview and you don't want to get sick, panicky, or having headaches and things like that during the interview. If you want to book a room in your library, most of the libraries would have some rooms for interviews and things like that. Do it now because they usually get booked quite quickly. Usually people don't tend to give interviews at home, but it all depends. Okay, how stable is your internet? Make sure your doorbells are switched off and you have do not disturb labels at your door. No one is ringing your bell. No dogs, no pets, no cooking, please. All those things just distract and make interviewers annoyed. And do eat food in the morning of the interview. Okay, don't be empty stomach. You need to have appropriate glucose levels for the interview. Yes, I think that's only a couple of important things which I thought would be useful. So I think should we start with
Yeah.
the
Do you want to select your volunteer for the? You will start with the clinical scenario, Ajit.
yes.
Okay, then just go through the. I see there are very good
we have a couple of
candidates. They are enthusiastic. They want to participate. So assign one for the clinical, then the management, and then the portfolio. If you like.
I think let's do Mohammed for the clinical scenario. Mohammed Al Said. Sorry, because there are a couple of Mohammeds in the chats. So I think and let's do Lakshay for management, and Noor, would you like to do the portfolio station? Isn't it? It's just a random, guys. Nothing. I'm just. So let's do Mohammed. Mohammed, are you there? Mohammed Al Said.
Guys, this is a first session. Better we make mistake here and then learn from them. And please don't take it. It's I think opportunity to learn from.
So Muhammad, if you turn on your camera and mic, and then we'll time it as well. So
yes, please. Yeah. I mean, can you keep an eye and when you have 1 minute left for the station, can you just tell us? And when you are interviewing, just tell us at 8 minutes.
Yeah. Okay. So Muhammad, are you with us?
Hi everybody.
Yeah. Hi.
Yeah, I'm with you.
Okay.
Hi everybody. Thank you
Hi,
for
Mohammed.
your effort and your time. Thank you very much.
Thank you. So let me share the present. Wait a second. There. Okay. Can you see my screen?
Yeah, I can see it. Yeah.
Brilliant. So I think let's start here.
Okay, time is on. Okay, 1 minute left. Time's up.
Okay. So, Mohammed, have you read the scenario?
Yeah.
So, okay. So, how would you manage this situation?
Can I start or?
Yeah. Your time has already started.
Okay. So I got unwell septic patient in a resuscitation room with suspected necrotizing fasciitis of her right buttock. She is confused at the moment, and she is acidotic with respiratory failure as well. So these patients already having hypokalemia and dehydration as well. So this patient, I think she needs urgent assessment, evaluation, and resuscitation. The other issue is that this patient, her glucose is very high, and she definitely needs to start sliding scale as soon as possible. The other issue is that my colleague from the ICU discussed with the patient relative about a plan of non-operating on the patient and escalation of care and resuscitation without the surgical assessment done. I may need to speak to them at the end of my evaluation of the patient, and I will to discuss again with the family regarding my assessment and my evaluation and my plan as well. So first I will call my F1 and my SHO. I will ask them to meet in the resuscitation room. I know the SHO is still there. I will ask him to make sure that patient is already having 2 wide bore cannulas and already had a catheter inserted. And I will ask him to review the GP notes while I'm coming with my F1. Once we arrive there, I will resuscitate the patient according to the CCRIS protocol. I will assist the patient from A to E. I will activate the sepsis 6, starting by make sure the patient is already on oxygen, 15 liter via Hodgson mask. I will start intravenous antibiotics according to the TRUST protocol, and I will connect him to IV fluid in the form of Hartmann 20 ml per kg. I will make sure the urine is already monitored and some blood culture is taken and ABG as well. I will ask my F1 to speak to the microbiology immediately about this patient of necrotizing fasciitis, what types of antibiotic we need to start on, and if there is any other antibiotic to be given as well. Then I will keep the patient nil by mouth. I know the patient is confused at the moment. I will insert in G tube connected to a bag, and then after that I will make sure blood taken, including full blood count, CRP, urea electrolytes, amylase, protein profile, blood grouping and cross matching, blood glucose and blood ketones as well. I will start the patient on a sliding scale. Then after that, I will ask my F1, my SHO, to update me regarding the GB notes he checked and what types of medication he is on, what comorbidities, and what allergies she has. After that, I will examine the patient myself. I will do quick chest and abdominal examination and then focus mainly on her right buttocks. From the scenario, I think she's got necrotizing fasciitis and she's very unwell at the moment. I will call my consultant on call. I will ask their opinion because this patient is having necrotizing fasciitis. She is unwell. She needs urgent surgical intervention without any blood, without any more investigations. In the same time, I will ask my F when to connect the patient with potassium correction as well. Then after that, I would discuss with next of kin about my impression after examining the patient, and that the patient clinically before her presentation she is fit and well. She got COPD hypertension, but I think she is fit for intervention, which will be life-saving intervention. I will ask the anesthetist on call to come and evaluate the patient to assess her fitness for surgery. I will update the theater coordinator about the plan, and then after that I will discuss with my ICU colleague about the escalation of care. Definitely this patient needs ICU admission after the intervention, and I discuss with them why they think that the patient is not operable. Then after that I will update my consultant on call about the plan, and I will book the patient for debridement under general anesthetics, and I will speak with the next of kin that the patient she may need multiple sessions of debridement, and she may need, after improving her general condition, she may need some plastic input in the form of skin graft at some point. Then after that, I will shift the patient directly to theater after checking her recent observation in the resuscitation room before shifting to her theater.
Okay, so upon examining this patient, you found that there was cellulitis and crepitations, which was reaching till the anal canal and vagina. So, what is your plan for this patient?
Okay, so I think this is extensive necrotizing fasciitis. I think the main thing she may need is to have some sort of fecal diversion, especially around the anal canal. So I may discuss with the family that at some point may we need to do a colostomy just to divert the feces from the area to give it some time to heal very well, and then after that, given her age and her fitness, I think we can reverse her stoma at some point.
So, how and what are you going to consent the patient for?
Okay, so the patient, given the fact that she's confused, it will be consent for. We'll write down that the patient needs extensive debridement. We'll take all the dead tissues out until we find healthy tissues. This could be very extensive. Any dead tissue, we need to take it out. And then after that, it carries the risk of bleeding, infection, collection, pain, and exposed area, which may need multiple sessions until good healthy tissues reach. And then after that, I will write down she may need some flab as well. This carries a risk of anesthesia as well, including chest infection, closing the legs, in the lungs, in the heart, in the brain, and also there is a risk of death as well.
Okay, so do you want to do anything about based upon the examination findings? Would you like to involve any other team or specialty?
Yeah, we'll speak to the respiratory on call because the patient she already COPD and she got some sort of respiratory acidosis. So I will speak to them. I will speak to medics as well regarding. I will speak to the medics as well because the patient she is hypokalemic and she is hyperglycemic. I will also speak to microbiology after we did the debridement because we will send some culture for microbiology input. Then we'll discuss with them the best antibiotics.
Okay, so I'm the consultant on the call, and you are giving me a call. So if you can tell me about the patient, please.
Okay, hi boss. So I got this 49 years old lady with suspected necrotizing fasciitis. Clinically, she's not. She
Sorry,
has
who are you?
fasciitis.
Sorry, who are you, guys? Sorry, who are you?
Sorry. So my name is Mohammed Al Sayed. I'm your surgical registrar on call tonight. I got a very septic 49 years old lady. She usually fit and well apart from COPD and hypertension. She presented confused with clinically necrotizing fasciitis. She is septic with hypokalemia, hyperglycemia, respiratory acidosis. We start resuscitating her. I don't think she will be need any investigations. So I think we need just to refer her directly to the theater for urgent deployment. I spoke with the ICU team. They are aware about that. I spoke with the respiratory on call. I let the medics know that the patient is already going to theater. At the theater, they are ready. I spoke with the anesthetist on call who saw the patient and assessed her fitness, and she's ready for intervention. I consent her consent for because she's confused. I spoke with the next of kin, which are in agreement of our plan. I already consent her for extensive deployment, plus or minus multiple sessions with all the risk, including this.
Okay, I think Mohammed, that sounds like a plan. I think ship the patient to the theaters and I would be there. So one last question, Mohammed.
Time up.
Okay, that's all right. So yeah, what do you think, Mohammed? How have you done?
It's really very tough. Whoa.
So I'm not.
Muhammad, yeah, start with the good things and
Yeah.
things to improve. Yeah. We are always good at criticizing ourselves, but not to speak about the good points. And you made good, very many good points, by the way.
Okay, I think I got the clinical issue. I got the managerial issues, which is my colleague spoke in behalf of me without assessing the patient by the specialty they involve in taking plan. And then after that, I think I start resuscitating the patient, include multiple teams, not all the teams, but multiple teams as well. And we didn't shift the patient for any CT scan or anything like that because the patient is confused. She needs urgent intervention. Spoke with my consultant. I spoke with the ICU about why they spoke with the relative without waiting for the surgical input, and also included them in the plan as well that we need to refer the patient to ICU post-operative. We spoke with the relative. There is a plan already ready for extensive debridement. There is also another plan for future plan for recurrent session of debridement, and also end plan of grafting or involving of plastic surgeon at some point. I involved the microbiology team early and involved them after the operation, after taking some cultures. And but I think it's still I have some organizational issues. I don't take the scenario very smooth. I just run here, jump there, come back here. I think this will be improved with practice.
I think honestly speaking, I'm not sure how much you have already practiced, but if you are just in your starting days of practicing, I think you have a very good level to start with, honestly. And I think if you will continue practicing, you can improve, like you'll improve drastically because you have a structure in your mind, but I think you are aware of the key buzzwords which interviewer wants to listen to, and you went through the scenario properly in a logical manner and escalating it and involving all the communication things which you could do. And I think there was if I go through the scenario objectively, I think you identified the scenario, sorry, you identified the main clinical problem, right, which I think Nazar said that get the main stuff absolutely right. Okay, so you on the outset you said, okay, this is neck fash. You're not beating about the bush. No, this could be cellulitis or some butter abscess or things like that. So this is we know this is probably neck fash. So and you made it here that it is an unwell patient. You need to give urgent attention. So you were very clear on that. And you pointed out a couple of other clinical scenarios and you processed the information and gave us your impression, what you think, acidotic patient, electrolyte abnormalities, and things like that. And you did point out one managerial, the organizational issue. Obviously, we did miss up on a couple of them. We'll talk about that. You did a detailed assessment. You mentioned the buzzwords of CRISP, sepsis, SAKES, and went through few components of that. I was glad that you did not went in a lot of detail of that. And also, I think when you will practice, you will sort of make your own, fine couple of lines for this initial assessment, and say it, like you'll be slick during this interview. You inform the consultant, I think, about all the important stuff, issues which you feel are there with the patient and what you have done. And you did not give a call to the consultant just like that and with no plan. It was good that you had a plan, so that if I'm your consultant, I know, okay, this man is thinking right, and he has a plan, and then I can change the plan, or I can fine tune the plan. Couple of things which I think which you could improve is that you should have mentioned that this patient has septic shock from the starting. You did not mention the word septic shock. And the scenario itself says that patient is sepsis. Before that, I think you thought this scenario was big. Believe me, brother, these are the scenarios of such length which you will be getting in the interviews. Don't go by the small 4-liner, 3-liner scenarios. You won't have them. You will have 5-6 issues in them, because, and I'm sure when you read through them, you will feel 5 minutes or less. So it is very important when you are preparing, you just at least list out the problems first, and then you can build upon the answer. Couple of management issues which is very common, which we don't point out, but if you point out, I think they are important. That in the first line of the scenario says you are in a small DGH. Okay, so you might, who knows, if you don't have an ITU. We have a couple of hospitals in our region who don't have an ITU, or this patient, you might not have enough theater staff to do it. So you need to tell that it is a small DGH. It's a night time. You need to tell them it is a night. It's night time. You might be having limited support in terms of staffing. Okay. So and after that, I think once you have listed the issues, you need to say it clearly that patient safety is your priority, because that is something they are keen to hear. So state out clearly that patient safety is your priority. Apart from that, when you needed prompting, when I said what do you want to consent and how you want to consent, this you could have brought up earlier on your own, that this patient is having alternating consciousness, so they would need a consent form for. You are right, but I would deduct marks for prompting it. You in the examination, I think in such scenarios, it is good that you say what you are looking for in examination. Okay, remember, this is a scenario where SHO has called you and telling about his findings. You need to be sure that what are you looking for? You're looking for involvement of anal canal, pubic, all the pelvic area. And when I told you the examination findings, I think you missed upon involvement of vagina, which was very important. And that was the point. If you should have involved gynae. And my escalation would have been that this is a small DGH and we don't have a gynae on site. What you want to do? Okay, so I think that was something which you missed. I think you did a good communication, next of kin, and all the allied specialities which you think. Obviously, I think a bit of this was overdone, involving medics and respiratory team. We know we don't involve them. ITU is probably the last thing you involve. But I think it is good, especially in these scenarios, which you can say that after the surgery, after he has recovered out of this acute issue. You did mention plastics, which is good, but we usually involve not tissue viability nurses, physios, and occupational therapists and things like that. So I think it is very important when we say these words, colorectal nurses, stoma nurses, and colorectal cancer nurses and things like that. So then they're aware that, okay, you are thinking about all these supportive mechanisms which we have in hospital. So And I think at couple of instances, you said that the patient was a he, and I think when I was preparing, someone pointed out to me to make sure you are not you're not assigning a wrong gender to the patient, okay, or sometimes assuming a gender. Because I think when I was practicing, I said, okay, I will call the SHO and tell him that do this, and then the examiner pointed out to me, oh, I think the SHO is a girl. So so I think avoid doing that. I think it is just natural, especially from the part of the world which where we come from. We are not used to these things. I think and this not is part of the culture, but I think we are preparing for exam and we need to be a bit more professional about that. I think that's all from my side. I'll leave it on to Nazar.
Thank you so much, Ajit. I think Muhammad, you got very detailed feedback from Ajit, and congratulations. As he said, if this is your start, then just keep building on it, and definitely you will be at a good place, hopefully the clinical station. So if I'm saying something to you, I will just say the signposting in your answer. So always signpost, right? Tell the examiner that it's issues, so he need to go down and put the marks now because that you start speaking about the issues, and always categorize things, make it easy for the examiner to do. But other than that, I think you got very detailed feedback from Ajit. I think that's fine. Thank you so much, Mohammed, for participating. We'll go for
Thank
the
you very much
management.
all.
You're welcome. Ajit, do you want to go to the management then?
Yeah, I think we decided Lakshay for management. Lakshay, are you around?
Yeah.
Can
Hi.
you switch on your camera? Oh,
Yeah, it's on.
thank you. You look very bright in yellow shirt.
Good evening,
Okay,
sir.
so Lakshay, I would be sharing the management scenario. Amira, do we have the is
Yes.
the timer ready?
Yes.
Well, then, so
Ajit,
just
I'm getting the same thing. Oh, yeah, it's here.
Timer on.
thank you.
1 minute left. Time up. Time is up.
Hello.
Yeah, time is up. Yeah, you can.
Yeah.
go.
Shall I start?
Yeah.
So, as per the scenario, I'm one of the surgical trainee. As per scenario, my consultant has already left the clinic, and I have 3 patients to be seen in the clinic, and they are quite
Yeah.
complex. Hello. Yeah, they are quite complex. So I have to see the patients by myself, and according to these 3 scenarios, I will see the patient one as on the priority basis, because he's coming. This patient is coming for the first time, and this patient has been referred by GP for the as per fit test, which is positive, and I will speak with the patient in the presence of a cancer nurse specialist, as this is a colorectal clinic. So, as for the first patient, when the patient comes to the clinic, I will inform about the GP reports, and will speak up and will take the proper history from the patient regarding how long this patient is having the bleeding from the bleeding per rectum, and what is the blood like, and if there is any history of loss of weight, loss of appetite, and if there is uh, 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 any abdominal pain or any mass, if the patient is there any mass associated with the mass coming out with the bleeding PR. And then I will examine the patient in presence of cancer nurse specialist, and on examination I'll check whether the patient has got any palpable mass, and after taking consent from the patient, I'll do the rectal examination of the patient, and to see if there is any if there is any growth, or if there is any mass I can palpate on digital rectal examination. After doing proper examination and history taking, I will explain the findings to the patient, and in view of positive fit test, I will explain the various possibilities. If she's having history of loss of weight, loss of appetite, I will explain the patient that there can be some pathologies which we need to rule out before we need to proceed further. So I will explain about the need for further investigations in the form of a camera test, which can be done as a 2-week wait pathway, and we will organize a camera test. Along with this, I will book a CT scan if she is having a history of loss of weight and loss of appetite, just to rule out any major issue, to look for any evidence of any sinister pathology. And after that, I will also see if the patient is being accompanied by the family member. Then I will explain the same thing to the family member as well. Along with this, I will give a leaflet, which is usually available in the clinic, in case if the patient has if the patient develops any sudden severe onset pain, and if the patient feels unwell, then they need to review us. This all will be done in the presence of CNS cancer nurse specialist, and we will uh, we will review this patient once all these investigations are done. And I will make a note that this patient will be informed of once the consultant is back. I will do the initial consultation, and then I will inform the patient that the consultant is not available at the moment, and but we will, as soon as the consultant get back, we will let them know about that this patient was here. For for the second thing, I will prioritize the patient who is coming back with the sigmoid cancer. There is a patient who had 53-year-old male with the initial sigmoid cancer resection in 2021, who is coming back with recent bleeding per rectum and loss of weight. So this patient is already being operated. So again, I will take a proper history in presence of cancer nurse specialist, and I will ask about the symptoms of the patient, and ask about if there is any abdominal pain, and as the patient is telling me about that there is a loss of weight and there is a bleeding PR. So this patient may have recurrence, but I need to take the history and proper examination of the patient. I will examine the patient in presence of nurse specialist, and and do an abdominal examination as well as a rectal examination to see if there is any growth, or if there is any mass or any lump I can palpate. And further, I will inform the patient that what can be the possibilities. I will also check from the previous record whether he has been given any post surgical chemotherapy after resection, and how, and what is the latest colonoscopy was done for this patient. And most likely he was lost to follow up, so probably he has not received any follow up after this. So I need to inform the patient about this, and we need to further request a colonoscopy to check for any recurrence. Along with this, I will also request a CT scan for this patient to rule out any recurrence as well as any evidence of metastatic disease. I will also check the previous records, including the oncology, if there is any oncology support from the oncology department, and will also check whether this patient had any previous stoma done, or whether it was a palliative procedure, or whether it was sorry, whether there was any stoma involved in this in the previous surgery. And uh, after the examination, after history and examination, I will inform the patient, as well as if there is any relative accompanied, that we need to do further investigations. And then I will also inform the patient that the consultant whom I'm doing the clinic with is not available at the moment, as the consultant is busy with the patient who is gone to see a sick patient. So I will inform the patient about this, and will let them wait for some time. Till that time, I will give some overview of what we are going to do for this patient with the investigations, and with these investigations. Third patient is a Ukrainian speaker who is having recently diagnosed with Crohn's disease on biopsy, and there is no interpreter available. So in such a case, I will review this patient as the third priority, and in this case, this patient, I will check whether any of the nurses or my colleagues who can speak the Ukrainian language. Otherwise, I'll check whether my hospital has a 24-hour available interpreter line, so that we can have some help from them to interpret about the biopsy report, and can be informed to the patient, as well as
2 minutes left.
uh, so that we can inform the patient about the report, and can discuss about the further management plan. Uh, Usually, if the interpreter line is available in my hospital, then most of the times I will I will inform the biopsy report in presence of cancer nurse specialist. But if the interpreter line is not available, then I will inform the patient about this, and most likely when the line is available and when the person Ukrainian interpreter is available, I'll make another early appointment after discussing with my consultant to see this patient again in the clinic.
What will be your action plan to prevent this condition from happening again to you or to your colleagues?
So you mean, I mean, that if the consultant has gone again?
Yeah, and all the aspects and scenarios. Like, for example, you are seeing someone who got language barrier and there's no interpreter available. Someone is being missed from the follow-up with cancer. If there is anything you can improve, it looks like your department is not doing well. You agree?
Yeah, so I think it is basically for follow-up, I will try to ensure that we have some pathways in place so that we can have quick reviews of this patient. Usually we do this as pre-operatively as a 2-week pathway, but after once the surgery is done, we usually follow the patients after every 6 months, and we make sure that the patient and the GP of the patient, they have appropriate information about the follow-up, and they are not missed into the missed
Time is
from
up.
the system.
Time is up.
Thank you so much. Actually, I think we lost Ajit, maybe because
Yeah, I'm here, Nazar. Sorry,
you are
my-
here.
my-
Okay,
back.
so it's over
the
to you
camera
then.
is not working. I don't know why.
No worries, it's over to you.
Apologies. Apologies. So I think, Lakshay, thank you for volunteering, first of all. I think this is a typical trap question for people where, you tend to go into more clinical details rather than highlighting the managerial and organizational issue. And believe me, this is the type of scenarios which are coming these days. Okay, it's not like simple scenarios where you're not getting enough lab coolies to do, and you're trying to get your logbook numbers. These are type of scenarios which are coming, and they are typically these long. So I think you got into the trap of going into a lot of clinical details rather than squeezing out the organizational issues. I think you did a couple of good things. Was that you told that clinical priorities is your utmost priority. You highlighted the clinical issues. You did highlight some management issues, including loss to follow up, no interpreter, and using lines. Sorry if I missed the initial part where you were trying to get to the consultant. Did you say anything? How would you like to get in touch with the consultant? Did you said anything about that? Sorry, I did not hear that.
No, no.
So I think that was the thing. What do you think? What you could have done better in this scenario? Now looking in retrospect.
So I need to call the consultant, inform about all the. I told that after seeing every patient, I'll speak to the consultant and take their opinion for what they want to do for these patients. I mean, I'll tell the patient that the consultant is busy with the patient who just came from A&E, and the patient is quite sick. But I'll inform my consultant that this patient is here and ask about their opinion regarding what to do and inform the patient as well.
So I think so. So do you usually, when you're seeing patients in clinic, do you discuss all the patients after seeing every patient? After seeing every patient, do you tell your consultant usually?
If it is a complex patient, then otherwise no.
Yeah. So I think all of these three patients, except for all of these three patients, uh, you can initially try to manage them. Because all
Yeah.
of these patients either need referral to appropriate specialty or doing initial investigation.
Yeah.
It's not that you need to chat with the consultant just right after every patient. It's not an A&E setting. It's a clinical setting,
Yeah.
setting. So it's quite an elective setting. Okay.
Yeah.
So I think when you were saying, no, I need to tell consultant after every patient, I don't think you usually also do that, and I don't think it is required as well. Okay. So I think
But
you
for
did
the
not have.
But for the ST3 levels, can we do that?
So why not? Because so okay, let me dissect through this scenario. I think this scenario was mixture of clinical and management scenarios. There are two ways of answering this question. One which I feel is better for me is that I
Yeah.
go through each patient. I go
Yes.
through each patient and highlight clinical and organizational issues for each patient. Okay, that just gives me a more ease to answer these questions. Okay, and then at the end I can highlight the teaching opportunities. So if I would have to go through these patients, so the first patient is a 79 male, has a positive Q fit. You know that this patient needs either a colonoscopy or CT
Yeah.
colon. So you
Yeah.
just say, I assess this patient clinically for fitness and appropriate investigation, which could be Q fit and CT scan. Just finish there. The second
Yeah.
patient is your 42 female who has Crohn's disease. This patient needs gastroreferral, okay, but you don't have an interpreter. So so the management the managerial issue in this scenario is that there is no interpreter. So I can you highlight it. You can solve this scenario at this point, or you can come back later. Okay, that there is no interpreter. I can use the language line, or I can use the my some staff member, and then refer the patient to gastroenterology. But if suppose if you don't have anyone, then what are you going to do?
I think I told that we can organize another clinic for this patient in as early as possible within 2 to 3
Yes.
weeks.
Yes, that's very logical that you arrange for a telephonic clinic or another clinic appointment, but you have to say that this needs to be sooner than later, because
Yeah.
you're canceling this patient and it is your fault. But at this was also the time where you should have highlighted that you can do an audit of the interpreter services, or a service evaluation, how commonly
Yeah.
the interpreters are not coming. Okay, so
Yeah.
this was the place to highlight that.
Yeah.
The third patient, we know that this is a patient probably having cancer recurrence, and
Yeah.
so you could have, you said that you will organize CT and colonoscopy, but you did said that this patient is lost to follow up, and what Nazar was trying to prompt was for you to say that I will look for the reasons why was this patient lost to follow up. And this was the place where you could have said, I would do this, needs a root cause analysis. Just throw that word to interviewer that okay, you're looking for the cause why this patient was lost. Okay,
Yeah.
if this patient, so you need to say that. And regarding the consultant unavailability, what ideas do you have? How can you try to solve that? What do you think? So obviously consultant is not available.
So is it is it the routine thing, or is it this only one thing once an event?
So I think, what is your short term? What are you doing to do in short term? At the moment, you are sitting in clinic, you're not able to reach the consultant. What is the short term thing you can do?
So short term, I can see these patients and make a plan, and I can I can make a plan and tell the patients about what we are going to do for them. But if it is happening again and again, then then I need to speak to the educational supervisor or clinical director about this.
Okay, so I think if we dissect into short term and long term, you could do a short term is that you can discuss with another consultant. There might be a couple of consultants running the clinic, or then the clinic consultant might be in, there might be another consultant next door. You can try to get hold of the registrar who might be with the consultant, because he went to see a patient in ward. Okay. Or you can, if nothing is available and you should sure the plans are more or less or correct or all right, you can email the consultant after the clinic, letting him know about the plans. And then it comes to long term. Obviously, if it is a recurrent issue, you need to discuss with another. You can discuss with another registrars whether it's this ongoing issue with all other consultants or only with this consultant, and then discuss in the clinical governance meeting, coming up with ideas of either bleeps for consultant, or cross covering the clinics, and or something like that. And and then this will also tell them that, okay, you know something about clinical governance as well. Was there anything else which you did not address or pointed in this scenario? Any another issue? So where did the consultant went to?
So patient, the consultant went to see a patient with an asthmatic leak, most likely an asthmatic leak post ileostomy closure.
Yeah, so I think this at this point, it is, you can I know it's like probably overdoing things, but at the end of the day, interview is all about show off. You can say,
Yeah.
I think that patient needs to be discussed in M&M because patient has operative complication.
Post-operative complication, yeah.
Yes. Okay. And did you highlight the teaching you know teaching problem in this scenario, that it is an unsupervised clinic and you have lost an opportunity for teaching? You did that. Okay, thank you. I think sorry, I missed that because of my internet.
No. I haven't mentioned about unsupervised thing.
Oh, okay. So I think this is important to highlight. So I think what's the takeaway from this scenario is that it's a mixture of clinical and management, but don't get carried away by the clinical stuff. Highlight them patient by patient, highlighting clinical issues first and then management issues, and focusing more on management issues and solving them. Your job doesn't end by highlighting an issue. You need to give some suggestions, or suggestions what you can do and what can be done. Okay, they are looking for solvers, they're not looking for people who are creating problems only. Okay, so I think that is what my bit is. And something like this has been coming in the last year. So I think I'll leave it on to Nazar.
Thank you so much, Ajit, and well done. Actually, I think you did very well in this station. You got very detailed approach for everyone, and you have detailed assessment. Looks like you worked in the colorectal department and you know how to deal with things. If I just need to point something to you in your answer, I want you next time to be more organized, signposting. For example, listing the issues, because the examiners, they just got the pen in their hands and they won't write this candidate list the issues or not. And it's sometimes tricky in the management scenario. What is the best way to list the issues? Is it to speak about generally the issues or take one by one? To be honest, I feel more comfortable with what Ajit suggested, is to take one patient and try to get the clinical issues and the organizational issue there, and then go for the next patient, and so on. I think this is the best way to do it. When we come to priority, I feel like I'm a little bit not happy with your priority. So you said you will see the patient referred by GB first because being referred by GB. I don't think that is enough reason for us to make him first. Yeah. So what I will suggest, the priority will go for that man who had missed cancer, post-operative cancer, and he came with weight loss and BR plead. And your concern is this patient now is coming with weight loss and PR bleed. Is he's very unwell? Is this metastasis getting him or blocked again? Is this PR bleed significant bleed? Because it's not like the QFIT test. This is PR bleed from cancer. So this patient might need to go for the on-call team to be admitted for urgent assessment and CT scan, because now we are in 2025 and this patient missed since 2021. And that's enough for this cancer to metastasize everywhere and to cause a lot of problems. So priority-wise, I will give him the priority. Now, you mentioned in your answer that that will be your assessment or what you are doing in front of the CNS. Most of the time, the CNS will not be available in the clinic, but they will be available on the background. Now, if you approach the patient with the cancer, I suggested more than what you have done. Besides the clinical assessment and to decide, do I need to investigate this patient now to be admitted for urgent CT scan, or I can definitely he need urgent assessment because you need to know where you are now with the cancer after this missed period. So there are few things you should mention with this patient. One of them is duty of conduct. This patient is being missed by your department, so you should be honest. Do you know how to conduct the duty of conduct? So duty of conduct is, first of all, you will get the nurse or someone to be available with you. And here you can say, I will ask the clinical, the nurse in charge of the clinic, for example, to be available with me, and I will speak to the patient. So the steps of the duty conduct are like this. Number one, first of all, you will explain to the patient what happened, which is that he had a cancer operated, yes, but he's been missed in the follow-up. So we are not quite sure what happened to his cancer. Yeah. So what happened? And number two, the impact of what has happened. So you tell him that because we missed the follow-up, there are few concerns here that this cancer might coming back again, or this bleeding might be just a mild thing. But given that you lost the weight, I'm very concerned that there would be most likely recurrence or worsening things with the cancer, and that necessitates urgent investigation. So number one, what happened? Number two, what the implication or the impact of what has happened? And number three, what you will do to rectify the situation. And here you will speak about you will assess him, and then you need to do urgent images either today, or if you see he's well enough, can do it as soon. But that's not patient. You will bring him next clinic appointment. This is something should be done urgently. And number five, you will assure the patient that you will make sure that these things will not happen to other patients. Yeah, and then you will tell him there is something called ethics. I will that's this issue. So this is definitely you should mention that. You should report it at the incident. And the aim is to make everyone aware and to think about how we prevent this from happening again. So you assure the patient, yes, this happened to you, but it's hopefully not going to happen to someone else. And then you provide him with the contact details for PASS, yeah, because he might need to complain, yeah, and should be very honest about that and tell him if you want to complain and also stuff. And then remember, this discussion is going at your level. Say I have difficulty in getting hold of my consultant, but definitely I will speak to my consultant and I will try to arrange for meeting between my consultant and you, so you can discuss this issue further and you will be reassured by my senior. Yeah, unfortunately, right now, I can't give you exact date for that, but I will be very keen to contact you sooner to tell you about that meeting. Yeah, so this is the duty of conduct for every, even never event. Anything that you need to do is explain what happened, the impact of what happened, what you are going to do to resolve the situation, how you are going to manage these things from not happening again to everyone else, that is, and then pulse contact. Yeah. Then I felt you looks like you're quite senior at your practice. That's why I felt you need to remind yourself that you are doing this interview as a ST3. ST3, he's a court trainee yesterday, or still court trainee, and he's going to be a registrar. So he's always someone get his senior involved. Yeah, so always involve your senior. Yes, you might feel that this is straightforward cases. I made plan, but you are thinking now as a maybe trusted registrar who is very experienced, even from his home country and here as well. So I don't need to involve anyone, but the examiner look at you as a ST3. So expect you to get hold of someone. As Ajit said, you should answer that concern. You lack in supervision. What you will do. So my advice to you is suggested is you will try to get hold of your consultant. If not, then your next go-to man will be the or consultant will be the on-call consultant. Yeah, you can speak to the on-call consultant, say, and briefly, I got these cases, nothing acute, but I want to make sure that what I'm doing plan now, you are happy with that plan, and I will try to get hold of my consultant and speak to him. Yeah, and if the on-call consultant is busy, then your next step will be the lead of the department. Yeah. Yeah, and this is your escalation from consultant wise. But if the clinic said you are busy, this is not the case now. But in other scenarios, they will say you are running like out of time, many patients to see, then you start asking for someone to come and help you in the clinic. But this is, you just want someone to reassure you are doing the good things. Now, coming to the long term, you should mention that you are going to speak to your educational supervisor, because you've been on difficult situation, lack of supervision, dealing with complex case, given that you are ST3, yeah? So you say, I will speak to my educational supervisor and try to reflect on this experience that I lack supervision, and I see if he can also have that discussion with the consultant, because I'm very concerned that the consultant is not trying to reach to you, and he got clinic and he just is not reachable. And also you can show some sort of sympathy that I will check about this consultant, make sure that he's all right. Might be he's just coming on the way and he had a car accident, for example. You say, I will make sure that the consultant is, and then this patient, the second patient scenario, is being missed from the follow-up. Now you sorted this patient, but your concern will be you don't want to have another one is being missing right now. Yeah. So what you need to say is, I need, after this is a long term now, you speak that you will speak to the lead colorectal consultant, and you did that is already, and that will be notified, but you need to speak about other patients. So you say, I want to make sure that there is no other patient being missed. It's just exactly like when they, for example, your colleague has a problem and the nurse said, come and see this patient urgently because your colleague was absent, it's not reachable, we can't get hold of him. You will say, I will see this patient and I will ask the in-charge nurse to make quick round, make sure that there is no other. Always think about other unwell patients. So your long-term plan will be is to speak to the in-charge lead colorectal consultant and also the lead colorectal nurse, and try to go through the database of all the cancers we got and make sure we are on the top of everything and there is no one missing. Yeah, and speak about doing audits and project. One of the audits I can suggest for you here is to do audits about how many patients we missed in the follow-up, and bring that to the M&M or the audit meeting and just raise the awareness of the colorectal cancer. We need to do something. So there should be a database. If there is no database, you should think of project of making database for cancer where all the patients will be there and they will be followed. We are running out of time, but I hope that makes sense to you.
Yeah, thank you.
Lovely. Thank you so much, guys. Let's go to the last station, the portfolio. I'm not sure who is doing it. Is Muhammad Khattab available?
I think we thought it would be Noor who would do that, but I'm not sure if she's.
Yeah, I saw
there.
Noor is texting that she's not well prepared. She would like if someone else can do it. But Noor, if you are happy or anyone happy, just let us know, guys.
Come on, guys, the last one.
Yes. I think people get tired now.
I think no one wants to tell what they've achieved till now.
Okay, I can go for it.
Okay, is this Noor? Yeah. Okay, Noor. Sometimes it's difficult that you don't want to share your portfolio with other people, but trust me, guys, this is the best way to learn is from the feedback, and trust me, we are all the same. Yeah. This is the best way we can learn from each other. Okay, Noor. So in this station, there will won't be any scenarios or any questions will be shown to you. The examiner will just verbally ask you the question. Okay. So Amira, do we have the time ready?
Yes, we have 10 minutes, yeah.
Lovely. So Noor, I would like you to speak about your teaching experience, if you don't mind.
Right. Fine. I have got a vast experience on teaching since I have been graduated, since graduation, and I came. Since I came to UK in 2021, I've been an anatomy demonstrator for 8 months in Newcastle University Medical School, and I have taught first year, second year medical students and also other professionals, and I learned a lot about from the anatomy as well while I was demonstrated there. I have been a teaching fellow in while I was in transplant surgery for 1 year, and has taught the third year, fourth year, fifth year medical students, and has arranged multiple teaching sessions. It included ward-based teaching sessions and simulation-based teaching sessions as well. And I've been doing a PG Cert while I was a teaching fellow, and it had not only helped me to teach as well, but also I gathered more knowledge, and I revised my knowledge and improved myself and as an SHO, and also uh, uh, upgraded my knowledge according to register level.
That's good. And looking at the list of audits you have done so far, tell me about the best one you are the most proud of.
I was an SHO in while I was in Newcastle Surgical Rotation Program. I did my one of the best audit I did was while I was in pediatric surgical rotation. Although it's not a general surgery related audit, but I did a full cycle audit there, and it was related with the monitoring of the pediatric surgical patients catheter on the wards, and also involving the ITU. And it really changed the management in the pediatric department. And it came in my mind while I was doing ward round with my consultant, seeing a patient developing catheter related hypospadias, and the child was suffering so much. That's why I decided to do the audit and led that audit, and came to my supervisor about my findings, what led to do that, whether we have a trials guideline, and the methodology, and the total population, including 57 children, including 9 pediatric wards in our tertiary care center. And we found that there was so much negligence in the catheter care. No trials guideline was followed, and also none of the patient who has complication has been ultrasound scan or urology input. So I came up with the idea, and uh, 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 came up with the idea and have my intervention as in a form of a infographic poster presentation and teaching session to the nursing and junior doctors and all the other staffs in the ITU as well. And did my second cycle, which showed much improvement, and it is still continuous. And there is a lead consultant who is in charge to run the cycle every year. Even I have moved from the department.
Good, well done. And what about your achievement after you submitting the application? Have you added anything to your portfolio?
Yes, I did co-author publication regarding telemedicine in surgical care, that was published in December, and I was co-authored there, and it was a narrative review. And also I'm doing a research project with my consultant related IBD as well. And I'm also involved in a second cycle audit project involving development of a pathway of the iron deficiency anemia patient in elective colorectal cancer patients.
That's good. That's good. And tell me more about your operative experience.
I'm working as an SHO at the moment in a colorectal department, and as an ST3, I'm mostly concerned about developing my skills into the cases that I need to be confident at. I have done so far 45 laparoscopic and open appendicectomies, and also I'm trying to build up my skills in having lab colis, although it's difficult at an SHO level, but every operation, when I'm scrubbed in, I'm trying to do bits and pieces of the operation. And also I'm confident in doing minor procedures, including incision and drainage of abscesses, and the local and hernia operation as well. And I'm building my skills on laparotomy, and mostly taking consent for the complex cases with my consultant as well.
And what about laparotomy?
I have done 20 laparotomies so far, not skin to skin, but trying to do like bits and pieces, trying to do stomas and part of the laparotomy under supervision.
Okay, that's good. Thank you so much, Noor. We'll stop here. How do you feel about the?
I'm not prepared at all. Like it was so jumping, like answers.
Yeah, that's expected. Yeah, this is the first time, and you're not expecting to present a portfolio as well. But now looking backward at your performance in this station, what are the things that you did well?
Mm. I think I have so much to tell, like in teaching station, but I couldn't like say so much, like what I did and what I learned. I need to tell more in an organized manner. And regarding the audit, it was not a general surgical audit, I know, but I've all my general surgical audits are QIP. So I did mention about this audit. I got prize and presented in a national conference. So I decided to go for that. And operative experience, I don't know how to organize that, but I should tell my exact number of DOPS and PBS I did. I don't know.
Yeah. Okay. And what I will say, do you have your portfolio written like in a PDF or?
Not yet.
Yeah, I think that would be helpful. Try from today is write down your portfolio. This is one of the things that we don't do, most of us, is to write down your portfolio. Look at your, because if you write it down, then you will see your achievement, and then as Ajit mentioned, you will see something in your portfolio you're not paying attention to, but it is amazing. If something is not being like done by everyone. Yeah. So you might have some sort of leadership somewhere, a role there. And then when they ask you about the leadership, you felt like this is nothing, but for the examiners is a massive thing, especially as a SHO. My advice to you is write down your portfolio, and everyone, by the way, write down your portfolio and reflect upon and categorize them into. You can start by the employment history, but mainly your operative skills, what you have done so far, and then teaching, and then leadership if you became like road organizer somewhere, or if you are organizing the M&M meeting, for example, or if you are teaching, the organizing the teaching, departmental teaching, or this all leadership. And then if you write them down, you will discover a few things, especially when you look backward at the certificates. But in terms of your performance, well done. Actually, I felt like you have very good portfolio. It's amazing that you are still SHO, but you achieved more than what we expect from a core trainee or SHO to achieve. So you should be proud of that. And you just need to go down and to sit down and to go through the portfolio and see how you can sell it. I will start by the camera. So the camera is showing only the top of your face. Yeah.
Yes.
So make sure that the camera is fine. Yeah. And then in the teaching, you spoke very nice about it. You said the impact of what you have done in teaching on you. I want you next time to add what you are looking forward. So always when you speak about leadership, about teaching, and so on, speak about what you achieved now and the impact of what you have achieved on you, and show them the enthusiasm about you are planning to do this in the future. For example, I'm planning to take, for example, PhD, MD in medical education. Yeah, show them that you are looking for someone. So it's not someone who achieved and stop here. Yeah, and this will be the same for the leadership. And then, as I said, the answer for the audit you went through very structured way. I can see you mentioned the problem regarding the catheters, and then you thought you take the lead on that and show your leadership that you want to improve the care here. And then you spoke to your consultant, and then you said there was no guidelines. Is that right?
Yeah.
Yeah. So what I will say, because audit need guidelines or need something to measure against. So I will.
There was trust guideline, which I
Oh,
did
yes.
complete, but it was not completely followed. So that was
Yeah,
my
lovely. So the measure is there. So what I would say, rather than say there is no guidelines, I would say there is a trust, because the guidelines either to be national or to be regional or even to be at the level of your department or hospital. Huh? So I will say this is what they target and what they want us to have 100% or 65 of patients should achieve this one. Yeah. And then from there, you will speak about discussing this matter with your consultant, agree, and then you speak about your team and the methodology you did for the audit and what is the outcome. And then the second cycle, what is the difference between the outcome? And then, as you said, you managed to present it. That's a very good.
Did I
So,
to
sorry.
like did I need to mention like figures like my first cycle result showed this like numbers?
Yeah, yeah.
Yeah.
This is also you need to mention in summary. So, like for example, most of the cases that they have, for example, the urinary catheters, only 40% of them had followed the trust guidelines. So you mentioned the number because when you do the cycle, I expect that number to go up. So you show me when we repeated the cycle and when we repeat the audit and completed the cycle, we found that there's a much improvement. Now the number, the percentage is 65%. Yeah, and also you will speak about what your suggestion between the first and second cycle of the audit. What were the change you suggested? Like, for example, if there is any poster, did you do lectures, as you mentioned? I think you mentioned you did some presentation, teaching, all this stuff. So mention what you have done, and then the second cycle, and if there is improvement, and then where you present this audit, and show them that this audit changed the practice. Okay,
Yeah.
so let's agree, guys. We need to go through these questions, make structure for them, and prepare yourself from now. So any practice should be clinical management and portfolio station. Lakshay, you want to ask question?
Yeah, I just want to ask about if they ask about the operative experience for the international graduates, what should we answer in that question?
That doesn't matter. You speak about what you're comfortable with doing it and what level of experience you have. Like for example, we got from level 1 up to level 4.
Okay.
Yeah, and level 4 is the one consultant.
Yeah.
Yeah. So if, for example, in appendix, I expect you to have level 4 now by ST3, but for lab quality, doesn't matter. See, it could be level 3, for example. Okay, so what the structure should be is to speak about. You don't need to go through the deep things about intercostal drain and all this stuff, but you just summarize them as Noor did now. But then you need to speak about the lab chole, you speak about the hernia, you speak about lab chole, you speak about laparotomy.
Yeah. Okay.
These are, I think, the most important things for you as a ST3.
Okay.
Lovely. Ajit, do you want to add any comment before we?
I think we have it's 10 o'clock now, and I think we have discussed in detail, and everyone is probably sleepy. I think only two bits I need to tell. We all agree that you need to write down your portfolio, prepare for the answers, and sort of practice it every day. Okay, and you can just verbalize it, and you can record it, and listen it to yourself. Are you making any sense? Okay. Second thing, when we are talking, when someone asks you about teaching or management or leadership roles, I usually tend to get it, tell it in a time frame. When I was a medical graduate, I did this. Then as an SHO, I did this, and now I'm doing this. So that makes interviewer understand that, okay, that you have been involved in various roles over so many years. And if you are asked for audits and publications, what I tend to do is that if they ask me, okay, tell us about audit which you are proud of. The problem is that if you have done a lot of audits or publications, you want to tell them that you have done a lot, but obviously they have not asked you. So a cheeky way of doing that is, I've been involved in around 10 audits, but the one which I am very proud of is particularly looking at sort of something, role of antibiotics prescription about after lab appendicectomy. And also when they ask you why are you, which one you are proud of, it is very important that you tell them why are you proud of. Okay, So you can say anything, it changed the practice, it brought money to the trust, or you got some prize presented internationally, things like that. And last thing is, uh, uh, if what I was saying was that regarding the surgery levels, okay, you need not to go in details of all the surgeries which we have done. I think they're just looking at common ones: incision and drainage, lap appendix, gallbladder, lab gallbladder, laparotomies. I don't think they're expecting us to do right hemis, left hemis, and things like that. I think you can just say, I can make a safe entry into the tummy, do a mask closure, or do a small bite, whatever is practiced in your trust. So don't get worried about that much a lot.
Just to want to ask this because they have an access to our logbook which we have uploaded as an evidence, so they will.
No. So,
They don't have.
as
Okay, that's
again,
fine then.
Mia said that they cannot see it physically, but obviously you don't lie, because they can always cross check and it is recorded.
Okay.
Amira, thank you for the opportunity. Over to
So
you.
yeah, I know that there are a couple of hands up, but we're, I think, beyond, like, everyone now is tired and we've overran it. But I believe that I couldn't actually stop it after 2 hours with all the useful tips from Nazar and Ajit. So so anyway, this will be recorded in a few days. It will be in the YouTube channel. You will receive an email maybe by tomorrow. We'll have the dates of the future sessions and links to subscribe to it. And please help us and help Nazar and Ajit by filling up the feedback form. And good luck, everyone, in shortlisting and in interviews. We're available if you want to send us any questions. I think Nazar already put his email, and you know how to, like, you can email us even on our email of that ESSGB email, and we'll try and help you. So next session should be next week, next Saturday, but we'll send you the email with all the details. Thank you, everyone, and good night.
Thank you, everyone. I think it was very informative, and please give the feedbacks, because whenever you tell anyone about teaching, you need to tell them about feedbacks. So I think give us the feedback so we know how can we improve or what we did better. Thank you, everyone.
Thank you.